In this video, we will discuss about some of the important terminologies used in occlusion. So, to start with, what is an occlusion? Occlusion is divided into two entities. One of them is called dynamic occlusion, which is really a relationship or act or process when you're opening your mouth, closing your mouth, or moving your jaw around. And that's called dynamic occlusion, which means it's keep moving, constantly moving. The other element is called static occlusion, and that's a relationship between incising or masticating surfaces and when they are close together. And in real term, we are not really bothered too much about static occlusion because you hardly function in that exact moment. However, when you're para-functioning, sometimes static occlusion becomes important. And that's why although we check just static occlusion, we really need to check dynamic occlusion and static occlusion together when we are assessing some occlusal issues. These are the definitions you can find in Glossary of Prosthodontic Terms. So, when you're looking at occlusion, what I would like you to look at is the whole masticatory system, because occlusion, it doesn't include just teeth or TMJ or muscles of mastication. You can involve in occlusion teeth, periodontal ligament, gums. You can relate to muscles and TMJ, but more importantly, neuromusculature system. And because of this, it's a complex system, which we are trying to make it as simple as possible. So when you're looking at some of the issues, you need to consider all of this together. For purpose of this series of lectures, we are assuming that the rest of it, the TMJ, the neuromusculature and everything is normal, and we are concentrating on the teeth. However, if you look at the harmony, how they work together, if you have some issue with teeth, it can affect the periodontium and TMJ. But if you have some issues with TMJ, it can affect the occlusion and masticatory system. So if you have an effect with muscles, it can affect the occlusion and temporomandibular joint. So as you can see, that is all interconnected, and treating or having effect of one can affect other issues as well. So when you're treating patients' occlusion, you need to keep in mind that you're not just treating occlusion, you're possibly impacting other elements of the masticatory system as well. So let's talk about some of the important terminologies used in occlusion. So one of the most important terminology used in occlusion is terminal hinge axis. And what is that? That is when your mandible is opening or closing, and the purely rotatory movement happens when open and closing action without the contacting of the teeth, where the condyle is in a rotatory movement. That's called terminal hinge axis in a simple word. And here is the definition. And when the condyle is fully seated and is in terminal hinge axis when it's rotating, purely rotational movement, that's called centric relation. So simply put, the centric relation is when mandible is opening and closing in a purely rotational movement without touching the teeth. So that brings us to three other important terminologies used in occlusion, which is CR, CO, and MIP. It is also called RAP, RCP, and ICP. And this is where sometimes the confusion comes. However, you do need to learn and make sure that you understand all these terms, because when you're reading papers, some people will use either of the terms. So CR, as we discussed, is relationship between mandible and maxilla when masticating muscles are relaxed, and it's a teeth apart position where the condyle is most anteriorly superiorly position. And because of the inclination of the eminence, the condyle cannot just completely sit on the top superiorly. So it's a slightly superior and anterior position, maybe 1 o'clock position. The CO, this is very important terminology because many times people get confused between CR and CO. CO is centric occlusion. However, it's not an occlusion, it's a contact point, but it's called occlusion. So when your jaw is in CR, as we discussed, it's non-contacting, it's not contacting teeth. So when it's doing purely rotational movement, in 90% of the patients, when they close, they usually have one tooth contacting first. And that first contact is called centric occlusion, which means the jaw or condyles are in a centric, which is centered, relationship, and now you're occluding, although probably in just one point, and that's called centric occlusion. From there on, the jaw slides forward, the muscles helps the jaw slide forward and to get the maximum intercuspation. And that's called MIP, where all the teeth are close shut together in their maximum contact between maxillary and mandibular teeth. And maximum intercuspation is very useful for us because that's what we worked by when we're doing simple restorative work. However, if the tooth has CO, which is a first point of contact, and if you're treating that tooth, you may need to be aware that that tooth has got first point of contact, because if you eliminate that first point of contact, then now the jaw slides, that slide can get affected and the condyle can seat more upwards. And we will go through this in more detail when we're doing clinical examination and discussing about various applications. But for now, you need to understand that the jaw, when you open your mouth and all the muscles and everything is relaxed, should be in CR. When you start closing your mouth, and when it contacts the first tooth, that happens in 90% of the patient or over 90% of the patient, that's called CO. And when you continue closing, the jaw slides forward and a little bit upward and to close into maximum intercuspal position. And that's called slide, and when the jaw closes, it's called MIP. And there are some patients, maybe 5% of the patient, where there is no slide. When patient close, they close purely into MIP, and that becomes CO equals MIP, which means centric occlusion and MIP is the same. However, as we discussed, it is not that common. So let's look at centric relation in slightly more detail. So what is centric relation? So when condyles are in centric relation, the disc is properly aligned on both condyles. You have condyle disc assembly, their highest point possible, which is a superior anterior, because as we discussed, that's the anatomically highest point possible, against the posterior slope of the mandible. The medial pole of each condyle disc assembly is braced by bone. The inferior lateral pterygoid muscles are in a relaxed position and are passive, so they are not firing up and they are not contracting. And more importantly, the TMJ can accept firm compressive loading with no sign of tenderness. And this is something very important for us because we will be assessing this when we're doing clinical examination or when we're recording jaw apart position using Lucia jig. And this is one of the reason, or one of the only clinical reason where you can say that the TMJ is in CR, because you cannot really, unless you have a MRI vision, you cannot really see the capsules and the disc and how the TMJ is seating. So what is the definition of CR? And this is the most recent definition of CR. And you don't really need to remember everything, but you need to remember 4 important key words or elements of this definition. One of them is the CR is independent to tooth contact. And this is very important. If the teeth are contacting, the patient is not in CR. So if you're mounting models in CR, the models needs to stay apart when it's mounted. So that's called CR. So it's a tooth apart position. The condyle, as we discussed, is anterior superiorly positioned. When my patient is in CR, the jaw movement is completely rotatory movement. So when you're opening your mouth, as you know, that up to around 25 millimeter, jaw is rotation, and then when you open more wider, it translates, so the condyle moves forward. And because condyle moves forward to open wider, it's no more seated and most anteriorly superiorly positioned. So although it's a tooth apart position, it's not completely anterior superior because it's moved forward. And that's why that translatory movement, when that happens, the jaw is not in CR. And more importantly for us clinicians, it's repeatable reference position. So you can repeat this position a number of times. Now, many times people ask questions that, how do you know the condyles are in a most superior anterior position? Why people are so fussed about CR? And they are correct that you don't really know for sure that the condyles are most anterior superior position, even if you've done bimanual manipulation, or you use leaf gauge or Lucey to relax the muscle, or NTI splint or Michigan splint. You can do everything possible, but it's very difficult in general clinical practice for you to know that the mandible or condyles are in CR. So really why we are bothering about centric relation, and why we need to really care about whether the patient's in centric relation or centric occlusion or not. So one of the reasons why we need to understand this is because it's a tooth apart position and there is no influence of the teeth. And because of that, it doesn't change over the time much. You have unless the TMJ system has deterioration for various systemic diseases, the CR stays almost constant throughout the life. And because the teeth are not affected, you can go back to that position again and again when you're doing full mouth reconstruction. Because when you're doing full mouth reconstruction or you're doing multiple restoration, you risk losing a reference point. And because of that, you need to have a reference point which you can go back to repeatedly in order to make sure that you are dealing with one bite rather than taking different bites different time when patient comes in. And that becomes a very, very important issue. Now, as I said, that many studies shows that you don't really need to fuss too much about CR, and CR is not a holy grail as people has made it to be. And you can do your dentistry without understanding CR. However, if you're doing complex work, it becomes a tool rather than a holy grail, I would say. It becomes a tool. And if you know CR, if patients in CR, then you can get more predictable results. You're not really working with your imaginary position or a bite. Now, and also one of the things is it's a natural position of patients to have, and it's not a diagnosis or a disease, as we discussed before. So now that you know CR, let's discuss about what is CO to MIP slide. So as we discussed, that when the mandibular movement happens, the jaw moves from CR and it contacts the first point of contact, and that's called CO, and the jaw moves forward, and that's called MIP. And only this forward movement, which is called a slide, happens in 90 to 95% patients, which means 5 to 10% patient, the slide doesn't happen. So when patient close, the CO equals MIP. However, in my experience, I don't see that many patients having CO equals MIP. And if you are seeing, let's say, 20 patients, 19 of them are CO equals MIP, then possibly you're not guiding patient enough. Patient jaws are not relaxed enough to go back into CR and then go into CO. And that's what you need to really first understand. If you find that your finding is CO equals MIP, you really need to question whether that's the truth, or it's just the muscles are so tense that you cannot really relax those muscles. However, in those 90% of the patient, the slide can be anything between 1.25 plus or minus 2 millimeter. So it could be huge as 3.25 millimeter. And that's the reason we need to really understand the tooth which is causing this slide, or the first point of contact. Now, the slide is divided into two components: horizontal component and vertical component. So when something closes in an arc, it doesn't close perpendicular, it's always in an arc, like a round shape. So there is always forward movement and always upward movement. Now the forward movement is called horizontal slide, and upward movement is called vertical slide. And what study shows that the majority of the patient have more vertical slide than the horizontal. Jaw still moves in an oblique plane like this, so it moves horizontally and vertically, but that line is more steep, so that jaw moves more upwards than sideways, and that's good for us, and you will see why in later lectures. So when you're looking at the terminologies, when you're assessing patient's slide, you need to describe the slide as either it's got long horizontal and small vertical component, because as we discussed, it will have both components. It's just that one of the component is usually longer than the other component. So if the jaw is sliding forward more and slightly upward, then it's called large horizontal, small vertical. Whereas if the jaw is moving more upward and slightly forward, as again it's oblique, so a jaw doesn't just go up and forward, it goes obliquely, and that's called large vertical, small horizontal. And essentially, if you eliminate that slide, the jaw seats upward more, and that's fine, that's not a problem. For us, it's better. However, if you have a long horizontal slide, and if you eliminate slide, jaw pushes back, because it's nothing, you eliminate that slide, so it's got nothing to slide towards forward, and it just goes upward. So you need to understand that when you have a large horizontal slide, when you eliminate, the consequences of that could be major. So that's why you need to really understand, because you could create anterior open bite. It could be that the patient's jaw is closing and moving forward into MIP, and you got nice anterior contact. Now if you remove the slide, the jaw moves backwards, and then there is open anterior bite. And that's why large horizontal, small vertical slides are more tricky to treat, and that's why you need to be aware of the slides. So let's look at one of the example, or just a video, short video, to show you a large vertical, small horizontal slide. Now it's a very small slide, and that's why you will have to look at carefully, but nonetheless there is a slide. So as you can see, the jaw is closing, and now you can just about see the slide, which is jaw is going upward. Now this is a little bit better position. So now this is patient's first point of contact, and now you can see that black triangle near the premolar is reduced, and that's when patient goes upwards and sideways. So when you're looking at this slide, when you should alter this slide, you know, it's not a pathological. As I said, 90% of the patients have slide, and majority of them, they don't have any issue. So slide per se doesn't need to be eliminated. However, if you're treating the tooth which has got a slide by using a crown or something, then you need to be aware of it to see what is the implication of removing slide. Also, if the slide, it has a very detrimental effect. So if the jaw is sliding forward and hitting the anterior because of the teeth moved and now patients created large slide, then eliminating that slide can give that comfort and reduce that trauma from occlusion. Also, if you are doing full mouth reconstruction, then you really don't want to build in a slide. So you want to try and create CO equals MIP in your full mouth organization cases. However, if you are trying to eliminate slide, the best way to assess is by giving patient an occlusal Michigan splint and assessing that in the mouth. If the symptoms goes, then there is no need to do irreversible damage. You just give patient a splint therapy and that helps. And that's why, I mean, I hardly reduce slide on its own unless it's a part of my treatment plan where I'm doing full mouth reconstruction, or if I'm treating that particular tooth. Now, the other terminologies you will come across is called freedom eccentric, and that simply is when you have this kind of slide, to reduce the effect of the slide, what clinicians can do is create a small freedom. So when you close your teeth, you can move the jaw a little bit around without discluding the teeth immediately. So there is no immediate disclusion. And that, some of the papers suggest that can give a better comfort to the patient when patient can not feel that their teeth are locked in. I don't do this very often. I would just simply follow a normal guidance pattern, and I don't tend to incorporate this kind of freedom eccentric very often in my cases. However, I have done it in some particular cases, and we'll go through later on which cases in advanced course you can do this kind of treatment. Now, the other important terminologies we need to understand is working side. What is working side? What is non-working side? And what is occlusal interferences, or what I would like to say is non-working side contacts. So the working side is the side where the jaw is moving. So if you're moving your jaw towards the right side becomes the working side, and the right condyle becomes the working side condyle. And that condyle purely rotates because you're going towards the right side. If you are, and the left side becomes the non-working side, because that's the side which is not doing much work, because you're chewing on the right side. So the right side is working, left side is not working. So the condyle on the left side is called non-working side condyle. And that condyle, it orbits because jaw needs to shift a little bit towards the right, so it shifts something like that. Now, because it orbits, the path of orbiting that path could be in a different ways, and we will discuss that in a minute. Now, when patients closing the teeth or moving the jaw laterally on the right hand side, if any contact happens on the left hand side, those contacts are considered to be a non-working side contacts, and many people still believe that it's a occlusal interferences. And in my examination, when I do full mouth assessment, I see that kind of contacts in almost 60 to 70% of the patient. on a healthy teeth, it's fine. However, if you have these kind of contacts on a heavily restored teeth, as we discussed in first lecture, then you need to probably make patient understand that that tooth is going through a heavy pressure or heavy load and it needs some treatment. However, and we will discuss that later on this lecture. And because of that mandibular position movement and some of the detrimental effect, people tend to call that occlusal interferences. However, in my opinion, it's not an interference, it's just a non-working side contact, and you really need to decide whether to treat the patient or not, or treat that tooth or not, per se. So now, coming back to non-working side conduct, there are three terminologies associated with a non-working side conduct because it orbits and the path could be varied. So one of the important terminology is called immediate side shift. So what happens is when the mandible moves, orbits, sometimes it just moves medially and starts going downwards and forward. So it doesn't orbit in a circular motion. It always goes downwards and forward, but before it starts going downwards and forward, it literally shifts sideways. And that's called immediate side shift. So, and that is on average 0.75 millimeter or less. Many times it's close to zero, which is good because if the mandible moves completely sideways when you open your mouth, it will have detrimental effect on the teeth because you will not get immediate disclusion because it hasn't gone down and opened, it just moved. So having immediate side shift can have some detrimental effect on the teeth. Now, the other terminology is called progressive side shift, which everyone has, where jaw moves forward and downwards, okay, and anteriorly, so in three plane. Now, this is similar to when we discuss the slide, horizontal and vertical component. The jaw moves. It moves in a three-dimensional plane, forward and downward and sideways, or medially, but it's in a gradual position, and that's around 2 to 3 millimeter shift. Now, if you combine those two components, you get Bennett angle. So if you look at the sagittal plane and you look at the trajectory, how the mandible moves, the angle is created because mandible is moving downwards and forward, is called Bennett angle. And the Bennett angle is around 7.5 to 12.8 degrees. And these are the three terms which confuses many of the dentists. In my opinion, yes, you need to be aware of immediate side shift, which is very rare, but when it happens, it can have a detrimental effect on the teeth. However, with regards to the Bennett angle and progressive side shift, everyone has one. So as far as you work with the averages, you are fine there. Now, the other important angulation you need to understand is condylar inclination. Now, I say 25 degrees because that's what we set in our articulator, but it's not really 25, it's more than 25 degrees. But in articulator, if we set the condylar inclination to 25 degrees, then you have less chances of teeth clashing and you have more chance of getting better anterior guidance. So as you can see in the picture, the condylar inclination and the anterior guidance inclination, your protrusive inclination. If the condylar inclination is less than your anterior guidance inclination, then your teeth will be opening the jaw because it's steeper and it sort of opens the jaw much quicker before the condylar inclination kicks in. However, if the condylar inclination is high, let's say 45 degrees, and you kept the anterior guidance to 25 degrees, you'll have your mandible moving forward and putting too much pressure on the teeth before it then discludes the teeth. And that's why, to be conservative, we would do 25 degrees in articulators, and again I will go through the articulator settings later lectures. Now, the other important terminologies you need to be aware of is called curve of Spee, and curve of Spee is simply anterior-posterior relationship, or a curve which is made up from the tip of the canine and all the buccal cusp of the posterior teeth. So when you join them together, the arc which is created by joining them together is called curve of Spee. Then you have terminology called curve of Wilson. The curve of Wilson is mediolateral curve which connects buccal and lingual cusps of the mandibular teeth, and is in a rotatory movement. So let's look at how all this affects your clinical practice. So if we look at the condylar guidance, again as we discussed, if the condylar guidance is steeper, you can do taller cusp because you can get immediate disclusion. If your anterior guidance with the teeth is steeper, then your cusp tip can be taller, because as soon as you try and move forward or sideways, the teeth disclose immediately. So if you have a taller cusps, you cannot have interferences because the disclusion is immediate. It doesn't go slowly, it goes quite high straight away. However, if the guidance is not steeper, it's a shallower guidance, then you need to have a smaller cusp tips. Otherwise, you will have your back posterior teeth contacting and not anterior teeth will not disclude immediately. The plane of occlusion, if you have a more parallel plane to condylar guidance, then you have a shorter posterior cusp. Again, as we discussed, that if the condylar guidance is low, then you have a shorter posterior cusp tips. Now, curve of Spee is very important when you are looking at the anatomy, and many times when you're doing full mouth reconstructions, many times people do not see the curve of Spee, because curve of Spee, if you have a very acute curve of Spee, then when patient moves forward, the disclusion is not immediate, whereas if it's a shallow curve of Spee, the disclusion is quite immediate. And that's why when you have an acute curve of Spee, the cusp tips needs to be shorter so it doesn't really interfere. Whereas if you have a flatter curve of Spee, because the disclusion is quite immediate, you can have a nice anatomy of the teeth. And that's why when you're looking at full mouth reconstruction, you really need to look at the curve of Spee. Same thing with curve of Wilson. If you have a optimum curve of Wilson, what it allows you to do is the maxillary teeth helps the bolus of food push inwards and improves the masticatory system. So you can masticate better if you have a appropriate curve of Wilson. And patient won't complain about the cheek biting or reduced function because of that. Now, with regards to looking at the immediate side shift, as we discussed, if patient has a complete immediate side shift, then the cusp tips needs to be shorter or smaller. And if the side shift lateral movement is greater, also then it needs to be shorter, because otherwise it will clang into the teeth. Now, when we're looking at the teeth position and teeth contact, we need to understand few terminologies associated with the teeth contacting with each other. So the first one is called tripodization. So what happens is when the teeth contacts, you can have either one contact, 2 point of contact, or 3 point of contact. What historically been taught is that three point of contact, if you have, which is like a tripod, you get the best stable occlusion. However, the problem is when you have one contact lost because of the chipping, breaking, wear, then you end up losing that stability. And that's why, as you can see in the third picture on your right, I prefer a flat landing surface. So rather than a contact, if the tooth has a flat landing surface, that is much more better and a long-term stability. It will have longer-term stability if you have that kind of landing surface. However, if you're doing trapodization, which is technically very difficult to achieve, it's still okay and is still considered to be a good standard practice. The other relationship of the cusp to the other opposing tooth is either cusp is contacting or going into the fossa of the opposing tooth, or landing on the marginal ridge or in between marginal ridges. Now, if the cusp is going onto the fossa, then the forces are much better distributed. However, if it's on the marginal ridge, or worse, if it's between two marginal ridges, then you can get teeth splaying or teeth moving apart, food packing between the teeth, and all sorts of problems. So if you are, or if you can, try and achieve cusp to fossa relationship rather than cusp to marginal ridge relationship. Now, when we are discussing about dynamic movement, let's discuss about some of the mandibular movement. So when the mandible moves, there are three main factors comes into play. So first of all, muscle pulls the mandible and moves them around. The bone guides it. If there is no bone, then the mandible will go wherever muscle will pull towards. And fascia and ligaments restricts it so that mandible cannot overstretch. So you cannot pop out of the socket. The jaw cannot pop out of the socket. And these are the three components needs to work in harmony. And when this harmony is broken, you can get some TMJ issues or mandibular movement which is not really functional. So when it comes to mandibular movement, we have divided into functional and non-functional movement. In functional, you have chewing, swallowing, and speaking, whereas non-functional movement, you have all the parafunctional habit, which is bruxism, clenching, and different habits like pipe smoking or pencil biting is also parafunctional movement. Now, you may have seen this arc, and this is, you need to understand it, but you don't need to get overly confused about it. What you need to look at is the number 4, which is a smaller arc, and that's your typical jaw movement. However, the side border is called border movement, and your jaw can function within those border movements. But usually your jaw functions within number 4, which is typical function. However, when you're doing parafunction, it can go within the outer line, wherever, however you are parafunctioning. So let's look at this slightly in detail. So if you close your mouth, which represents the a top of the right up to the top point, and now you're sliding forward, grinding forward to make it edge to edge, which is the second point. When you're now opening your mouth, you have rotation of the condyle, and that literally moves the jaw forward, and that's where the point is, where the 1 is written. And when now open wider, when it becomes translatory movement, jaw goes slightly backwards and forward, and that comes right at the tip of the curve. Now when you're closing, you don't get that same movement. You just, mandible closes almost in CR, and that's why it's posterior. And then you get a slide and the contact, and then maximum intercuspation. Now, you're not going to do that kind of movement when you are functioning. You're just going to have half an opening and a smaller circular motion when you're eating. And that's why this picture is made up like that. I just wanted you to know, when you see this picture, that you understand what it is for. However, in practical reality, you're not going to do tracing of these pictures. However, you could if you were to while you're doing Lucia jig. Now, there are two determinants of mandibular movement. So, two factors which affects how your jaw moves. One of them is anterior determinant, which includes your actual tooth to tooth contact between the upper and lower jaws, which includes, canine guidance, groove function, protrusive guidance, or your posterior determinants, which really is TMJ assembly, which includes the condylar guidance. You cannot really control posterior determinants. So what you can control is anterior determinants. And that's why we are more concentrating on anterior guidance. Now, it's mainly anterior guidance is provided by teeth, and anterior guidance is not a protrusive guidance. As I said, it includes canine guidance, lateral and protrusive. We call it anterior guidance because it's dictated anterior to TMJ. And that sometimes becomes confusing because when we say anterior, we relate straight away to anterior teeth. But just to make it clear, it's anterior components, which is your teeth. And that includes protrusive, lateral guidance, groove function, and canine guidance. So, why we need to really worry about the guidance? In 30s and 40s, people really did a denture teeth, and the same anatomy of denture teeth or same scheme, occlusive scheme of denture teeth in their normal full mouth reconstruction cases. What happened is they noticed that when they did this sort of a balanced occlusion where teeth are guiding both sides, when the jaw moves on the right, the left side teeth is also contacting, right side teeth are also contacting. What they started seeing is that they started seeing more fracture, chipping and breaking of their full mouth restorative cases. And the reason behind that, if you want to understand, then you need to understand how the lever works. So let's look at this lever. So this is class 1, class 2 and class 3 lever. So when you're looking at P, which is the force, it's the power, which is muscles. F, which is a fulcrum, is your condyles. And W, where the work is happening, is your teeth which are contacting. Now, class 1 lever, as you can see, cannot happen in your jaw because you cannot have work happening behind your mandible, behind your condyle, because F stands for condyles. So now we're looking at class 2 and class 3. So let's look at the class 3 lever. So if you look at the jaw, F, as I said, is fulcrum, where it happens in your condyle area. P is power, which is masseter muscles, and W is work. Now, if you look at this nutcracker, if you put the nut closer to the joint or where the power is, and if you try and crack the nut, it will crack because the power closer to the force closer to the muscle is quite high. However, if you put the nut near the handle, right at the tip of the handle, and try and crack it, you will need tremendous amount of force to crack that nut. And that's the essence of it, that you want to keep the work away from the force as much as possible. And when we say work, we mean guidance. When you are guiding the teeth, teeth are in contact. So when I say work, it means teeth contact and guiding contact. As soon as the teeth are open, the mouth is open and you're chewing, it doesn't really matter. You want to chew with the back teeth because that's where the forces are higher. You're not contacting your teeth while you're chewing, so it doesn't really affect your restoration as much. So you want to chew with the back teeth, but all the guidance you want from the front teeth, because that's when the teeth guides when you're functioning, parafunctioning, and you don't want too much load on the teeth when teeth are guiding. And that's why you want class 3 lever. However, what happens when you are doing, let's say, working on the right hand side, moving your jaw right hand side, and now you have a contact on the left hand side molar. Now that becomes a class 2 lever, because your force is coming from the masseter muscles from here. Your fulcrum is here because that's the rotating, that's the orbiting conda, and your work, which is a guidance, is happening here. So the guidance is between the force and the fulcrum, and that's the worst case scenario, because you are now using the power between the fulcrum, and the work is happening in the middle, and that's why that tooth can be highly likely can break if it's weak already. If it's not weak and patient's functioning like that, then leave it, because patient may have adapted, and this is something we will discuss in a future lectures, that adaptive capacity of the patient is really, really important. That's why you see many times patients who have severe wear not having any pain or issues, whereas sometimes patients with very minimal wear and non-working side contact have some issues or TMJ pain, because those patients' adaptive capability is less. So this is a very important concept to understand, and this is the reason why people do not like non-working side contact. But as I said before, you only need to treat if it's broken. So if you have large amalgam restoration or large restoration where you think you're worried that the tooth may fracture anyway, then this could be a factor which can lead to that fracture. So as we know that disclusion is important to avoid non-working side contact, what are different types of disclusion? So the different types of disclusion is bilateral balance occlusion, unilateral balance occlusion, and disclusion by a canine. So when you're looking at bilateral balance occlusion, it's really a denture occlusion where you are closing the teeth and both side teeth are guiding on either way. So it's a balanced occlusion. Unilateral balanced occlusion is more than one teeth are guiding on one side, and we call it a group function as well. And disclusion by canine guidance is called canine guidance. Now, as we discussed, the two main disclusion is group function and canine guidance. So the group function is when you're moving your jaw, let's say right hand side, you have more than one teeth are in contact, usually premolars and canine. And the canine guidance is when you are going right hand side, the canine is in contact and is discluding immediately rest of the teeth, right hand side and left hand side and anterior. And that is essentially guidance means. Now, you can have a partial or complete group function, which means you can have, let's say, canine guidance to start with, and then you have the first premolar guiding and then the second premolar guiding, and then at the end all three teeth are guiding together. So you can have a different variation of guidance, and when you're looking at the group function, whereas the canine guidance is simple, just have one canine guiding all the time. Now, factors deciding type of guidance is the vertical and horizontal overlap of your anterior teeth. So if you have an open bite, then your canine is not in contact at all and it's miles away from the lower canines, then you will have to work with group function. And condition of the tooth or teeth. So if you would like to do canine guidance, however the canine is post and core crown, then you potentially want to distribute the load when patient is guiding and maybe consider group function. So why we want canine guidance? Or many times people keep saying canine guidance is important, do canine guidance, and although I don't believe in just having canine guidance, I think the group function is as good as canine guidance, and some studies actually shows that it's better. However, it's more difficult to achieve and it's tricky to replicate. So that's why I prefer canine guidance for simplicity. But let's have a look at the canine. Why to choose canine as a 1-2? So it has a favorable crown root ratio. So it's got longer root and a crown which helps the palatal anatomy of the crown with the bulk of the canine and the shape helps in guidance. You have canine, which is one of the longest lasting standing tooth. You have more pedial attachment, so it's got more proprioception. As we said, the palatal surface of the canine is much more conducive and helpful, and it's mechanically in a favorable position, which means when you're using canine, you're creating that class 3 lever because the work is happening way forward than where the masseter muscle is. And that's why it's less detrimental effect. So if you're going forward, further backwards, so if you're using just a molar as your guidance, you will have a tremendous amount of pressure because of the lever action. So just to avoid that detrimental force, it's better to use canine. So again, why canine guidance? Because study shows that it decreases the muscle activity. Schultz showed in 1984 by doing various ECG studies that the canine helped in reducing muscle activity. During lateral movement, the occlusal forces are more evenly distributed by canine guidance. So you can distribute the forces of the occlusion because of the way the position it is much more evenly. And as we discussed on the top, it reduces muscle activity during parafunction. So it also, when you're doing canine guidance, muscle doesn't have to work very hard in function, but also when you're doing parafunction, muscles, it reduces actually muscle activity because muscle don't work to work very hard. And at the end, it's easy to deal with. And that's one of the main reasons I use or advocate canine guidance. It's very easy to replicate. So which cases you would not consider canine guidance and you would consider groove function? So some of the cases, such as when we discussed before, that when patient has class 1 occlusion with extreme overjet, where anterior teeth are not really touching, that's when you have to consider canine guidance. You have a class 3 occlusion where you really can't do canine guidance and you need to consider a groove function for class 1 and class 2, class 1 with overjet and class 3 occlusion. Some end-to-end bite, when you have a end-to-end bite, it becomes important to distribute the load because you don't have enough overlap of the canine, and you may want to distribute the load with the other teeth to get the better preference of the lateral guidance. Again, we discussed anterior open bite, and also we discussed that when the canine is weak and it's not suitable. So if I'm doing post-encore, if I have an implant, just a single implant canine crown, I would prefer to distribute the load using the premolars. However, if you're doing full arch cases, then you can still go using canine guidance. There is no harm in doing that. So what are the pros and cons of, what is the advantages and disadvantages of using groove function? So what the groove function does is, the advantage is that it allows distribution of stress, as we discussed before, and it's conducive to occlusal wear. So if you're just having canine guidance, and now what happens is over the time patient wore that canine, now the guidance will go somewhere else, or it will become a groove function. And that is slightly uncontrolled way to have a groove function, because canine is worn down, the guidance becomes slightly shallower and other teeth start touching. What if it's the molar starts touching? And that's why sometimes canine guidance can lead to changes in the molar guidance. So you start picking up the molar. One of the way to eradicate that is, if you're building canine guidance, in the articulated models, you can take that canine out and assess where the rest of the guidance is going. So you're future-proofing your canine guidance. So if you lose that canine guidance, you want the guidance to go to premolars and then mesial buccal cusp of molar. I wouldn't go further back than that. You could use a lateral incisor as well. So what is the disadvantage of using groove function? So it's technically demanding, as we discussed. To get a nice even groove function, it's very technically demanding. You always end up needing some adjustment, and it may not work without intraoral adjustment. So you probably end up needing a little bit of adjustment. So it needs a little bit more care when you're dealing with it. However, it's not a no-no. You know, you need to really assess on a case-by-case basis. And I don't have a particular bias between groove function and canine guidance. It's just, as I said, I use canine guidance because it's easy to deal with. What is protrusive guidance? So the protrusive guidance is simply use of all centrals and lateral incisors and sometimes canines to disclude the posterior teeth when you're moving your jaw forward. Now you could use just 2 incisors, you can just use 4 incisors, or you can sometimes use just canines to provide anterior guidance. So if you are having 2 to 2 post and core crowns, and you really don't want to distribute, or you don't want to give them any load because patients are bruxist, then you can build canine to give anterior protrusive guidance as well as the lateral guidance. And this is the scheme you can choose, and when you articulate, you can build it up with composite. And we will discuss about this in one of the lecture when we are discussing about the clinical application of what you're learning right now. So what is ideal occlusion? At the end of the day, we want mutually protected occlusion, whereby when you're guiding the teeth forward, you have posterior disclusion, and when you're chewing, you have harmony and there is no premature contacts of the teeth, and patient is maximum relaxed position. So you want to aim for mutually protected occlusion where you are doing full mouth reconstruction. You want to aim towards this type of occlusion for longevity of your restoration and protect them from future destructive forces. So in this lecture, you learned some of the important terminologies used when we are describing occlusion. And in the next lecture, we will discuss how I do clinical examination, especially clinical occlusal examination when it comes to doing full mouth case assessments.